Welcome, welcome. Well, it's one past the time, so I'm going to go ahead and kick us off and get started. Welcome back, Accelerator States, to our seventh Learning Track session. We'll be talking about partnerships with managed care plans and other delivery systems, including key decisions, best practices, and more. Next slide, please. As a reminder, please rename your Zoom square so it shows your name and state. It helps our hardworking facilitators a lot, and it helps people who aren't in your state know who you are and where you're coming from. As in the past, we are recording all parts of this session for note-taking purposes, and also please mute your mic unless you're speaking. Today, we'll start with some initial framing from NASHP. Then we're super pleased that Hawaii will present because they have a rich set of strategies and insights to share. Be sure to put your questions for Hawaii in the chat based on our August evaluation feedback. We're going to stay together for peer-to-peer discussion for this part of the session, which CSH will facilitate. Next slide. Because we're always striving to coordinate across federal TA initiatives, we're really delighted to have Ella Roth, Policy Associate at NASHP, frame the session. Ella, the floor is yours.
Thanks, Ryan. So great to see everyone. As Ryan said, I'm a policy associate at NASHP and I help to lead our Health and Housing Institute. Just want to kick off our conversation today by providing a little bit of context for the issues we'll be discussing, and sharing some learnings from how some states currently leverage their contractual relationships with managed care plans. A lot of this information is going to draw from a brief that NASHP published earlier this year, as well as many conversations we've had with states since then. Next slide, please. So as you all know, as states are expanding their coverage of housing-related services, managed care plans will be critical partners. And most states use contracted managed care plans as their delivery system for their state Medicaid programs, but the managed care plan models vary widely across states. So up front, I just want to note that as you are all starting to make decisions about what's the responsibility of managed care plans versus functions that are delegated to the state or other third parties for delivery of HRSN services. So this slide here has a few examples of that and how different states are handling those decisions. So next slide, please. And this slide just kind of summarizes these types of functions that will be key decision points for you all to think about who takes on which of those functions. So for example, last month, you all heard from North Carolina that they decided to use their network leads to develop their provider network, provide them with technical assistance, process invoices. Arizona is separately contracting with a services program administrator responsible for establishing provider network, verifying enrollee eligibility, among other things. I won't go through the whole list. And then Arizona separately has a statewide housing administrator responsible for the management and administration of housing subsidies. And similarly, Washington also has a third-party administrator for its foundational community supports program, that's really in charge of provider network, service authorization, referrals, eligibility, processing claims, and more. So these are some of the functions that will be important for you all to consider, and really important for us collectively in our evaluation to understand kind of what's working. Um, so at this point, we can leave these slides up, but at this point, I want to move on to talk about just some key themes of how states are leveraging managed care plans. And a lot of this will happen in concert with these other delivery system pieces. So I'm just going to highlight a few of the state strategies that really stand out that some of you may be less aware of or have less prescriptive requirements around. Obviously, there's a lot more that could be said, but you can find more info, including contract language in NASHP's resource, and I can put that in the chat afterwards. Um, so in terms of partnering with housing and other non-health players, some states are really requiring each of their managed care plans to hire a housing liaison, a housing specialist to be their point on all things health and housing. So that can include to help with care coordination, to engage COCs and providers, to engage community members or connect with other managed care plans in the state to share learnings or try to achieve some sort of standardization. Um, a key part of plan engagement with COCs is also to work towards data exchange with HMIS or with facilitating case conferencing about specific clients. So I'll highlight that Arizona is one state that requires its plans to cover any user fees associated with HMIS usage. So that could assist with care coordination, for instance, if plans pay for HMIS license fees for local behavioral health providers. Um, Also, most states do require some sort of reporting from plans to the state to assist with program implementation, evaluation, and targeting. So some states do require very specific items to be reported, including Medicaid and HMIS IDs, information about referrals and results. Um, in terms of more broad coordination, some states require plans to be coordinating with other partners, for instance, to connect people who are exiting incarceration and other institutions with housing. Some contracts require managed care plans to refer to one of those third-party administrators or another existing housing program. And then finally, I just want to mention payment. Payment incentives can relate to everything I just laid out, are a very huge piece of state and managed care plan relationships. So California's Housing and Homelessness Incentive Program is an example of a program that provided plans with payments for meeting very specific goals. And some states are also factoring the cost of services into the capitation rate and using the rate setting process to really incentivize plans to spend more on housing related supports through specific performance pools. So I know that was a long list. Those are just a few things to be aware of. And I also know from recent conversations that there are a few issues rising to the top for you all that I'll just highlight since they may be worth revisiting today. Um, Paying providers using invoices versus claims is a big topic. Determining eligibility, service provision and authorization timelines for services that may have kind of different considerations across systems. And the successfully layering eligibility for HRSN and other benefits, both within the Medicaid program and across programs outside of Medicaid. Um, so those are just a few things I wanted to share. I hope that you all can kind of use today's conversation to begin tackling some of those questions and hopefully also raise other issues that I haven't already mentioned. So thanks everyone for the important work you're doing, and I'll pass it back to Ryan.
Thanks so much, Ella, for those succinct frameworks for action with key decisions and reminding us of the delivery system models. Next slide, please. Now let's welcome and thank our Hawaii State team presenters, John Fuji, Anna Pruitt, and Vic Tolentino. John and Vic are with MedQuest, and Anna is at the University of Hawaii. As they talk, put your questions in the chat, which we'll use to facilitate the Q&A portion before we go into the broader discussion. John, we're ready to learn from your model and experiences. Next slide, please.
Thank you. So just want to say right up front, Hawaii is really pleased to be able to share with this esteemed HSPA group. We've already learned a lot from all the other states in their presentations, and really had some really good conversations in Rockville when we were in person maybe a month and a half ago now. So just want to say we're really happy, and we're finding this very beneficial, and pleased to share just some of our where we are with things and sort of how we see things in Hawaii, which related to these different services and how we're just working through it. But we by no means have everything figured out at this point. But willing to share what we have, what we've learned, and really excited for the Q&A as well. In the past monthly HSPA sort of meetings that we've had online, I think the Q&A for me has been the sort of best part of those presentations. Because there's a lot of detail that folks get into. But we have time, so let me move on. I just wanted to say that Ryan introduced us, but just want to get into a little more detail. So myself, I'm I guess my responsibility on Medicaid is over the health plan delivery system. So as what you saw with Ella presenting her slide around, Hawaii has chosen to partner with our managed care plans to deliver our CIS program. So that falls under sort of my responsibility and scope in the Medicaid program. Vic works with me. He's our APRN, one of our APRNs in our branch, and he's kind of in the weeds and in the detail level, working with all of the different partners and the health plans that we have for our CIS program. And Dr. Anna Pruitt is our rapid psycho assessment evaluator. And so she'll get into more detail around what she does, but that's something that was a term in our special terms and conditions for our 1115 approval for our CIS program. So just a little background, and let's go to the next slide. Yeah, so today we're going to talk about just who we are, some of the people, talk about our 1115 demonstration, which is through which we deliver our managed care program, but also through which we deliver our CAS services. There's going to be a little bit of discussion of a sort of pre-boot and reboot, and we'll get into those terms that we made up later on. And then we're going to talk a little bit about some of the challenges and solutions, and then Q&A at the end. So next slide. And next slide. So just some of the people that are involved that might not be on this call. Dr. Judy Moore Peterson is our Medicaid director. Some of you might know her from her time in Oregon previously, but she is currently the Hawaii Medicaid director. Myself, John Fuji, I report to Judy, and I'm over the Healthcare Services branch. Vic is administrator under the branch regarding the quality member and relations improvement section. Alana and Kathy are sort of key subject matter experts that we use. They're within our branch, and they help with a lot of the details and the on the ground and working through a lot of the details that we've worked through. I just repeated that twice. Douglas is our handy dandy project manager, and sort of keeping us on track with everything we're doing with CIS. Next slide. So this is just introductory to Medicaid in Hawaii. So our program is called MedQuest. We are under the State Department of Human Services. We do have a separate Department of Health, right? So there's Health and Human Services, two separate departments. Our Medicaid program falls under Human Services. That's the acronym for our Quest program. You can read that a little bit. I want to get to the vision is talking about the people of Hawaii embrace health and wellness. And this is specifically not talking about the Medicaid members embrace. So we see ourselves as part of the entire state sort of health delivery system. We are part of the delivery system. What we do impacts other parts of the healthcare delivery system, which hopefully improves the health and wellness of the entire state. And then the next thing around the mission is that with respect to our CIS program and delivering tenancy and pre-tenancy services, right? We see this as part of being innovative in how we deliver things, right? Looking at not just what's in front of you from a regular Medicaid insurance perspective, health insurance perspective, but looking at what are some of the HRSS that are impacting and driving some of the health outcomes that we're seeing. And so this is sort of us trying to be, stick to our mission and be innovative in how we look at our program and how we sort of expand out to different areas that typically aren't considered healthcare. Next slide. Every state, and this is our enrollment slide, our entire program. And for Hawaii, every state sort of went through the pandemic, the redeterminations and all that. So this is sort of us from the very beginning in March of 2020. We have it through, I think it's August. Yeah. So I think latest numbers have us around 402,000 or so. So we jumped a lot and then we sort of came back down. The reason it doesn't look like a smooth down is because we had the Lahaina wildfires where we sort of paused our redeterminations. So that's why it sort of goes down and then it kind of goes up again, because we did a pause in our sort of redetermination process. So in the end, I think Hawaii is like a lot of states where we net had a lot more. We have a lot more Medicaid folks in our program now, which means potentially a lot more folks that might need our CIS program. Next slide. Next slide. So Hawaii has the 1115 demonstration. So like I said, Hawaii runs our program through our managed care plans. The authority of that comes through our 1115. Our program has our managed care program has pretty much everything in the managed care through our managed care plans. Physical health, behavioral health, MLTSS. And we also run our CS program through our managed care plan. So this is a quick summary of what our current authorities look like. Our managed care authority, running behavioral health through I 15, home and community-based services. So we have both regular nursing facility and HCBS, obviously, through our 1115. And then at the end, it's community integration services. So it's pre-tenancy and tenancy sustaining supports, and a few other things that support those initiatives. Next slide. So right now, Hawaii is in the middle of renewing our 1115. So our current 1115 actually expired officially July 31st of this year. So we had an extension from CMS through March 31st of 2025. So as states that have 1115s know, or any other authority, they're waiting for CMS. CMS is a little bit of backlog right now with all that's going on with them. So same with Hawaii, we're sort of in the docket for approval. We're actually in the middle of negotiations right now. But this slide is sort of talking about what we have current authority for in the blue side, left side. And then the green is sort of additional things we're asking for. So again, on the left side, current authority, outreach, pre-tenancy, tenancy sustaining. We have a few more authorities that are grayed out there. Those we have authority for but did not implement. So that's why they're gray. You'll notice on the right side, we call it CIS Plus because we like CIS, but we need to have a new name, so we called it Plus. As we're adding on things, hoping to get authority for new things regarding our CIS program, we're sort of calling it out differently so people understand there's additional things here that's resources for both our agencies as well as our health plans as well as our members. The first thing is looking at how we can expand our 1 month security deposit, 1 month rent to 6-month rent, 6-month security deposit. Sorry, 6-month utility payments, as well as including and continuing some of those security deposit items and application fees. That's one thing we're adding or expanding on. And the other thing is medical respite. Excuse me. Medical respite is, we see it as sort of 2 stages of respite. One is up to 90 days, and the second one is up to 6 months. The first one we're calling it, I think we took these terms from California, so thank you, California. Recuperative care, short-term residential care, sort of ongoing things with the member that they need to continue to attend to, but maybe don't have a place to do that. And then short-term hospitalization, post-hospitalization, individuals who do not have residents, but they're continuing sort of a longer-term recovery on things. Let's see, did I miss anything? No, I think we can go to the next slide. And so now we'll kind of get into sort of what we call pre-boot and reboot. Dr. Anna is going to cover some of this, but before we leap off here, just want to be sort of, as Ella was presenting, I was reflecting on the different models that different states have. So, again, this is sort of, we're deciding to run through our managed care plans. By no means, obviously there's many different models and many models are successful in different ways. And we've enjoyed hearing other people talk about their models, and picking up bits and pieces of their models and maybe applying it to our model. But yeah, I'll just pause there and I'll pass it over to Anna, and Anna can get into some of the details of sort of what we went through as we were implementing our program.
Okay, thanks, John. You can go to the next slide, please. I think this is your slide, John. Do we want to skip it?
Oh, no. Yeah, we could skip it. We kind of summarized a little bit of this, so we can skip it.
Okay, thank you. So as John mentioned, the 1115 waiver required ongoing evaluation. And so MedQuest partnered with the Health Policy Initiative at the University of Hawaii to conduct evaluation of all the waiver programs, looking at both process, so how the programs were being implemented, as well as outcomes. So are the programs having the intended results? And so I am one of the researchers who is a part of that team. And I work primarily on CIS, and I'm a community psychologist who's done a lot of work in homelessness and housing, so it was a good fit. So for CIS, not only have we been looking at process and outcomes longitudinally, but we've also been using a rapid cycle assessment approach, or RCA. And so basically what that is it's an approach to evaluation that speeds up the data collection and analysis, and returning that feedback, those results quickly back to the stakeholders who are implementing the program so that they can make decisions in real time, can course correct the program in real time. And it really allows for this kind of iterative refinement of the program. And it really encourages using like evidence-based, or making evidence-based decisions. So not just making decisions about the program just based on like what you think might be happening, but what's actually happening. So this is a really useful approach when you're implementing a new and novel program like CIS that is kind of complex, hasn't been done in this space before, and you know you're going to have to make some tweaks as it goes along. So I think, MedQuest really showed some foresight in choosing this approach, because it's really been helpful in kind of seeing where things are going really well in the program and where things maybe need to be revised or rebooted, as you will hear from Vic in a little bit. One other thing, because I'm a researcher, so I have to always put a plug in. If your state is considering an evaluation approach, I do think this is helpful. Part of the reason is because it really focuses on a true partnership between the evaluators and the stakeholders. Because instead of coming in at the end of a program and saying, oh, your program worked or it didn't, we are invested in the success of the program. We're trying to help you make decisions to make the program successful as well. So I think, our team has been just as invested in the success of the program, I hope, as the MedQuest team. And so what we did was we held RCAs quarterly. So we would collect data from the MCOs and analyze it and then hold a presentation to all the stakeholders. And since the program began, we've really used the RCA to look at both program process and outcomes. But for this presentation, I'm going to focus on a specific RCA report that focused on process and implementation from October of 2021. So we're hoping that can show you kind of where we were, and then we can show you how we got to where we are. So that hopefully you can avoid some of the mistakes that we made, and maybe capitalize on some of our successes. So next slide, please. So programs like CIS have different levels of implementation, and of course the evaluation is going to be focused on all of those levels as well. So you have the program is implemented across levels from the policy level all the way down to the member experiences. And what happens at each of these levels might look different, but they impact each other. And challenges at one level can have impacts and implications for other levels. And so it's important to understand like what's kind of going on across all stakeholders, and across all levels. But again, for this particular RCA that we did in October of 2021, we really focused at that systems level, where you see the circle. So with MedQuest and the MCOs, looking at how things were going at that early stage of the implementation process. So you may notice some stakeholders missing from this map, and I would agree they were, and that was part of the issue. So you may notice there's no COCs, for example, or the homeless service system. You also notice there's no third-party administrator, so Hawaii does not use that. So there's more of that direct connection between MedQuest and MCOs that was really leveraged, I think, to build those partnerships. Also, some members of our team had connections to the homeless service system and ended up bringing in some of those players to the table. And so I would say that if we recreated this kind of map now, it would look a lot fuller, and we'd have a lot more of the pieces of the puzzle at the table. Okay, next slide, please. So in this particular RCA report from October 2021, we use interviews with MCOs and the two providers that were signed on at the time to kind of come up with, okay, what does implementation look like? So coming up with an implementation framework of what needs to happen at each stage of implementation. And then looking at what were some of the barriers and some of the successes that were going on at the time. So next slide, please. So we realized that there were kind of 3 implementation phases that had distinct activities at each one. Pre-implementation, early implementation, and ongoing implementation. So we just named them that. You can name them what you want. But this is kind of what we were noticing had to happen before the program could even really get off the ground. A lot of internal planning going on, a lot of connecting with providers, trying to recruit them to get provider status, contracting with them, and then of course a lot of training and coordination. So some of the key challenges that came up at this stage were things that along the lines of getting that provider status. There were delays in getting the applications completed and in and approved. There were struggles with the not having the capacity. A lot of providers didn't have the capacity. They didn't have the administrative capacity to kind of navigate that process. So we only had a small number of providers. So there was no one really to accept the members that were being, identified for the program. Some other issues that were coming up was it was a lot of work to contract. Even for one provider, there's 5 different MCOs, so having to contract with 5 different, health plans was a little bit challenging. And what we found was that a lot of providers were just like saying, no, this is too much work. We're not going to do it. And then, there was only 2 that were participating. So next slide, please. So there were a couple of MCOs. Most of the MCOs were kind of at this like early implementation phase, but there were a couple that were here at the early implementation. They were identifying members, they were outreaching them, and trying to get them enrolled and assessed. But there were a lot of issues at this stage as well. Things like not having, and this is something I think you've probably heard if you've been in any of these learning tracks, there was no centralized structure for sharing data across housing and healthcare systems, and even sharing, data for reporting was difficult because there's 5 different MCOs, 5 different processes. So that really presented a lot of challenges. Our state has 2 COCs, which I realize actually is not as many as some states, but still the health plans had to negotiate 2 different COCs doing things in different ways, getting access to their HMIS. And, that proved to be a kind of a heavy lift in some ways for some of the health plans. And then, of course, the providers had to navigate on their end 5 different processes for reporting, for billing, and for how they wanted their assessments done and things like that. So there was a lot of challenges in that way. There's a lot of challenges around billing, and I think Vic's going to speak a little bit more about that. But it was so challenging that the two providers who were engaged were threatening to pull out. And that's kind of where this whole reboot starts. And Vic's going to tell you how we managed to save the program. So, but you can go to the next slide, please. So I'm happy to say this is where we are now. We were not here in 2021 when we put this together. So we have now filled this out a little bit. So we are now in ongoing implementation, service provision, and we still have challenges, but we're working through them. So next slide, please. And if you want to see any of the more specific details about these phases, you can see the report. I'll put it in the chat. But really, what I wanted to emphasize is that these challenges really kind of reflected a larger issue, which was that CIS requires a collaboration between two complex and parallel systems. And to have a successful implementation, it necessitated system change, right? This was at the systems level. To make it work, we had to, change systems. We had to make them more flexible in some ways. And MQD really stepped up to facilitate that. They said, all right, well, we're willing to change and be flexible where we can. And we want to bring the right people to the table, and really facilitated that coordination and those partnerships. So I think that's where Vic's going to take over and explain how they did that and what kind of the outcomes from that have been.
Aloha, everyone. Next slide, please. Thanks to Dr. Pruitt, as always, or good Dr. Pruitt, for her thoughtful analysis and support of our implementation efforts. I also appreciate that she set up that suspense, so now I'm going to take us to the end with these next few slides. So we took the input that we received from Anna and her team really to heart. It was disappointing to hear, but also a big wake-up call for us that implementation was not going as we anticipated. So we realized that we had to respond quickly. We immediately gathered an internal team composed of staff with a range of backgrounds in program management, health plan oversight, and reporting. We also engaged a project manager who is texting us right now, telling us that we're over our 20-minute time, but I'll try to stick to things done to help track our activities. And we one of the first things that we did is dedicate 3 hours a week for our team to meet and focus on implementation topics. Our meetings had a set agenda, but allowed for flexibility for walk-on topics. And we invited, Anna mentioned, not having engaged the COCs, the Continuum of Care organizations, in the past. So we invited other key partners to join those meetings when needed. We also realized that it was very important to schedule time and engage in more meaningful ways with our key implementation partners, primarily the health plans and homeless service providers. So we scheduled meetings every 2 weeks with both of these groups separately to discuss a range of topics and use this time to obtain implementation advice from the frontline perspective, because these are the key groups that were on the ground delivering the service. And then separately, we made sure that topics that were relevant to the program got to the leadership level at the health plans. And so these issues were discussed at the executive leadership meetings, which involved our health plan CEOs and also Judy, our Medicaid director. And there were other health plan forums as well that we tapped into. For example, our monthly MedQuest and health plan staff meeting, and all health plan staff meetings. And then separately, there is a quarterly health plan contract monitoring group that's led by our contracts monitoring team. So next slide, please. So the collaboration resulted really in 3 separate implementation memos that were released over a 7-month period that describe the changes we put in place as a result of this community feedback. So the first memo was released in April 2023, and it focused on a revised payment methodology, which converted what we started out with, which was a fee-for-service model, time-based billing approach, to a task-based per member per month rate. So when the program was first implemented, there were 15 billing codes that providers had who had no knowledge of Medicaid billing had to use. So you can imagine that the learning curve for a homeless services provider to really learn about Medicaid concepts is steep. And you kind of magnify that with sort of the billing standard that we use. And so we really heard that that this made it challenging for the providers to implement the program. So we changed all of that, and today we have two codes, T1023, which we use for outreach services, and H0044 for pre-tenancy and tenancy supports. And these are reimbursed at $200 and $350 per member per month. This is all in the memo, and there are links. There's a link in the slide for you to be able to access the detail. The first memo also addressed input that we received regarding the clarification of roles and responsibilities around health coordination between the plans and providers. And we included language around the expectation that providers and plans hold regular case conferences to discuss members who are enrolled in the program. And we did that to document our expectation for collaboration between these two groups. The second memo we issued approximately, sort of 3 months later, and this described administrative simplification. So at the time of rollout, the assessment form and action plan for our members enrolled in CIS was over 5 pages each. I think the max was around 8 for one of the documents. And so, another administrative challenge for people who are working with a population that may not be so easy to reach and engage, if you can imagine. And so we worked very hard to reduce these assessment documents to about 2 pages, which is where they are now. And then in that second memo, we also described the members' flow through the program, which was useful for the plans and providers to understand the members' journey throughout the program and key touch points. So the third memo, we wanted to sort of end things before the holidays, and was released in November, and this described simplified reporting requirements and the timeline around that reporting, and these changes were made to align with the program changes that were implemented. So the memos are available again through the link that's on this slide. I think it's important to point out that our attention to the concerns that were raised by the plans and providers, and our response allowed us to develop trust. The engagement also highlighted for us the importance of building capacity for our MCOs, so that they in turn are able to support their contracted providers really in delivering the service, in a manner that's more efficient and really as free of as many barriers as possible. So next slide, and this one is a little bit busy and hard to read. Not gonna spend a lot of time on this. The good news is that this is available online in our third memo in a much more readable format. So what this illustrates is simply just the movement of a member through various touch points in our program. And again, the plans in both plans and providers found that this is really useful in identifying key touch points around eligibility, requirements, and timelines associated with CIS. So next slide, please. So the next 2 slides, and close to the end here, are summary slides essentially, which just really describe our key achievements since embarking on the reboot. So I described the changes to our payment methodology. I also talked about the importance of decreasing administrative burdens around implementation. And key to that was the simplification of our forms and reporting. There was a lot of sort of redundancy that we identified after we really took a step back and looked at what the forms were asking, what we were asking in health plan reports. And so we tried to consolidate that as much as possible and define timelines associated with those forms. As Anna mentioned, the feedback we've received recently is really through these sort of efforts, we've managed to boost the collaboration between our Medicaid system, which our health plans are key in representing our efforts in the community, and then our homeless service providers, who really prior to this had no contacts and limited contacts, I would say, and no experience or knowledge of all the work that we do in Medicaid. So there are some sort of what we think are positive results from all of this work. Our meetings with plans and providers are now once a month, and we actually had a meeting, I think last cycle that lasted just 15 minutes, and we dedicated about an hour. So because there were no questions. To date, we've served about 1,000 unique members, over 1,000. Anna mentioned that there were providers that were threatening to pull out of the program, and there were only 2 that kind of we were able to engage earlier on. Happy to report that we have now enrolled about 80% of our state's homeless service providers. So we see that as key. The journey has also allowed us to establish those deeper partnerships, that Anna mentioned are really critical to sort of pushing all this work forward. Our continuum of care organizations have been invaluable. We also now have more engagement from the governor's office on homelessness and housing solutions. The plans and providers are also more engaged with each other. So our health plans, for example, have volunteered to participate in the state's point-in-time count, also led by Anna. And they are connecting regularly. One of our providers actually issued a commendation letter because they were so happy with the collaboration that they received from one of our health plans. And so that really makes us feel good to see what we think is progress in those relationships. We feel that our openness to change and flexibility has really had a positive impact on the member experience. Next slide. So where are we now, and what are our future plans? And a plug for HSPA or HSPA, has really been helpful in allowing us to deepen again those partnerships. We have 4 main activities that we hope will result from our participation in the Accelerator. So like other states, we are creating a housing resources funding funding infrastructure map. And the reason we're doing that is so that we can better define the housing pathway for our members. We are also exploring how we can best leverage our CES system. As Anna mentioned, there are certain challenges around data sharing to allow for the identification and support of those members who are eligible for our housing services. Separately with our Housing Finance Development Corporation, we are exploring a Section 811 project rental assistance application. So if you're not familiar with this, this is something that we heard about through our HSPA coach. There's a link for those of you who are interested in learning more about this in the slide. And then we're planning to continue our community and stakeholder engagement as we expand our support services through CIS Plus. Next and last slide. Actually, one sort of add is Anna mentioned that there were some challenges associated with provider enrollment, and the solution that we quickly identified for that. It's not in our slides, but we engaged with a contractor to help reduce those enrollment backlogs. And so happy to report, John, I think that we now are our enrollment takes about 10 days maximum. And there's like zero backlog. So that's been super, super helpful. So I'll end with this slide. So, which just kind of highlights some of the strategies that we found successful. So, we want to really emphasize the importance of collaboration and partnership, of listening to and incorporating community input, in being flexible and providing really ongoing technical assistance to health plans and providers as they deliver these programs in support of our members. So with that, we're happy to take your questions.
Well, thanks again for a great conversation. We can pull back up the slides. Thanks, Marcella, Amiel, and Austin, and all the state teams for a great discussion. Lots of food for thought. And as a reminder, for Hawaii's slides and their separate PDF process chart are available. As the slide shows, we have one more HSPA webinar on October 10th featuring SILS. Be sure to register for that and spread the word. And in just 3 weeks, we'll be together for our final learning track session. Can you believe it? On scaling affordable and sustainable housing models. We want to give you a heads up that in addition to the usual prep with discussion questions, we're also going to ask you to choose an item from our resource list to read. So stay tuned on that. And next slide. Please keep actively using the TA community site. And as Marcella encouraged you, answer some of the questions that our federal partners posed to you today about how requests to better connect with COCs. Would love to learn more about how people are engaging our AAAs, SILs, and community hubs and other types of entities. And so please post on one general or state discussion board. And we know from today's discussion that you have a lot to share that's helpful to other states. So please make use of this resource for peer-to-peer sharing. And next slide. And as you heard in our opening, we really do consider the feedback that you provide on these sessions. So please complete the evaluation for this session by next Friday. You can grab the link from the QR code or chat, and we'll also send it again by email tomorrow. And next slide, just want to thank everyone so much for your active participation today. We look forward to be together again in 3 weeks. And next slide, I also want to thank all of our wonderful TA providers who helped pull off this incredible learning track session, and hope everyone has a great rest of your day and week.
Thanks so much, everybody.
Bye, everyone.
Take care.